volunteer professor in our department and also at NYU, where he teaches in the postgraduate psychoanalytic program. He's also a teacher, a supervisor in San Francisco at the Center for Psychoanalysis and the Psychoanalytic Institute of Northern California. He's the editor emeritus of Psychodynamic Dialogues and the author of Relationships in Development, Infancy, Intersubjectivity, and Attachment, which has been translated in multiple languages. He teaches internationally in the US and also in Europe. He's a very experienced child psychotherapist, and so he teaches with study groups and also includes members from California. He's had over 4 decades of experience in this field, and I think that in the past few years, it's been very clear that people who have infant mental health training and expertise might have something to contribute when it comes to us paying attention to relationships and connections. So we're very happy to welcome you.
Thank you. Thank you. Thank you, Dan Glowinski, for introducing me. I appreciate it. Thank you most of all to the department and to Gina Martinez for her support throughout this process, which was derailed for a variety of unexpected reasons over time. I'm proud to be here. I've worked in the department since 1978, actually. One quick correction. Dr. Glowinski, it's the Doctor of Mental Health program. And the Doctor of Mental Health program was a program started in this department by, maybe 3 chairmen ago, Robert Wallerstein, whose lecture is, we have a named lecture for him now. Anyway, it was an effort to provide a profession that would be, let's call it a more efficient route to mental health practice at the time. This was in the 1970s, combining pre-clinical training at UC Berkeley and then 3 years doing much of what residents do here in the department over at the old Mount Zion Psychiatry department and up at the old Langley Porter Psychiatry department. And the program didn't make it politically at the time, but there were about 60 of us running around the US. It was a proud, if failed, experiment. I went on from there to work as a fellow at what was probably the first infant mental health program in the world. It was in our department. Wallerstein invited Selma Freiberg, who was a psychoanalytic social worker, to bring a program, an innovative program that she and her colleagues had developed to the department here. And we set up at, she and later we set up at San Francisco General, where the program continues. And the infant parent program, many residents rotate through it now, is a program that serves the families of children 0 to 3 in the face of a wide array of socio-emotional difficulties, including the sequelae of abuse and neglect, parental substance abuse disorder, and other serious kinds of difficulties. The profession now has thousands and thousands of people working with families. That would be another presentation, but the short version there is that the family is the patient, the caregiving system is the patient, that we help the baby through helping the infant-parent relationships. And that is the theme of my talk for today, that humans are, human and human infants are born to evoke and respond to care, and that many of our fundamental motivations are social, and that the mental health professions, including, if not especially, the one into which I fall in psychoanalysis, have neglected that fact for a long time, and I'm glad to say are coming around in recent years, and particularly in the most recent years, to a fuller understanding of the importance of the social world. I'm going to make several points about from the burgeoning world of infancy research, and then I will, as we go along, and and at the end of the presentation, I'll try to make a number of points about what this kind of knowledge about infants tells us about psychotherapy practice. I mentioned the infant parent program, and I'll start with a general orienting point. Infants are individuals. Now, you might think, sure, infants are individuals. Why does anyone have to say that? But first of all, for many years, centuries, infants were understood as being quite a bit more disposable than they are now. And this was in part the case, of course, because infant mortality was a significant part of life for most of the history of our species. But to some extent, social policy, particularly in this country, among the developed countries, undervalues the lives and well-being of infants. Children, in general, men, women, children are the poorest Americans. The per capita income of children, that is, if you divide all the money available to each family, is the lowest of those three groups. Children of color are the poorest of all. Social policy allocates fewer resources to children and to young children and to infants in that order than other age groups. I wrote a piece when you may remember at the end of COVID, there was a $6.7 trillion proposal from the Biden administration, one of those acts, the Build Back Better Act or something like that. And it included a quite substantial $2 trillion, $1.5 trillion contribution to early childhood intervention. It aspirationally proposed to provide universal child care, expand early intervention for children under 3 and under 5. And that part of the bill was the part that was struck when a final agreement with the centrist senators Manchin and Sinema was reached. That's an unfortunate, if not tragic, decision. A great deal of there is now extensive research about the outcome, the short-term and long-term outcome of intervention into the lives of infants, mental health intervention, educational intervention. And a great deal of the research points to the following outcome, that over the lifetime of a child under 3 for whom appropriate services are provided, the social return in the aggregate will be 7 times the initial investment, inflation adjusted, 7 times. If there is a failed, the opportunity cost, let me put it that way, the opportunity cost of not investing in young children is tremendous. We at one time, there was a slogan or a response to this, which is, well, we don't know what to do. We need more science. We now know what to do about children. Most every other country in the developed world provides universal daycare, provides an array of services to children. In England, for example, every infant, the family of every infant is assigned a home visitor who follows the family weekly, and then as time goes on, monthly. This is not visits to home. This is not something that's regarded as a matter of pathology. Princess Diana, Princess Kate, all had home visitors provided by the National Health Service. We have nothing like this. France, Germany, and so on have universal childcare. We're lagging behind. It's one of the reasons probably that life is costing more and more here as the generations go forward. The second point about infants being individuals that I want to offer to set this talk up is that there are substantial individual differences between infants. And this is something that every mother, every grandmother knows, if you like. There are an array of differences. There are, of course, genetic endowments of the sort that we well know about in the behavioral sciences, genetic predispositions to various mental disorders, physical disorders, and the like. But infants, of course, vary in size and all of that sort of thing. But what's also the case is that infants vary with regard to soothability, with regard to their activity level, with regard to the extent to which they can tolerate or embrace sensory input, and so on and so on. And this again is the subject of another talk, but these are some of these matters, particularly neurocognitive, neuroaffective dynamics, proceed into older childhood and adulthood. I've seen a number of patients, children and adults, for example, who are not autistic, but who have difficulty with sensory integration, attention deficit disorder, other things like that, more subtle problems, which are contribute to socio-emotional difficulties, which are overlooked and often not diagnosed. When those factors are diagnosed and intervened with, a child who, for example, will become easily overwhelmed by sensory stimuli will be more likely to become a kid who will be seen as an acting out kid in the classroom, will become distracted, look for other things to do, and so on and so on. That leads to difficulties in self-esteem, social adjustment, so on and so on, impulsivity. And often when those kinds of things can be taken on, one sees remarkable changes. I could go on about that, but that's another talk, another seminar, and be glad for you to ask me about that in questions or approach me or write me later at my UCSF email. If Bo is here, Bo, are you here? Yeah, my slides are not coming up, I think. So you see, I want this on the screen. Anyway, yeah, I'll begin to speak about what I want to get at. In any case, let me go back now to my orientation to the decades of research about infants and children, infants and early childhood that I'm going to orient you to. I'm going to make a series of 5 points, or orient myself roughly in terms of 5 points in the time that I have. The first is that, and this is partly what you've heard already. The first is that infants are social, and that, as I said, that infants are born ready to interact with the world, to recognize other humans, to prefer humans to others, and to, most of all, to evoke and respond to care. The second point is that it has to do, and this taken together, these points are the core of my interest in my discussion of the implications for psychotherapy, that infants, and here I'm going to go to my point 3, that has to do with the centrality of mutual influence and mutual regulation processes in infancy, which are quite conspicuous in infancy and are nonetheless central to how we get along, to human relationships, and indeed to psychotherapy throughout the life cycle. The correlate of that is the importance of, we could call it fittedness and adaptation, or match and mismatch. What I want to say about psychotherapy and about infants and parents is that it's not a matter of what's right or wrong. It's not a matter of what's good or bad mothering care. It's a matter of how the therapist and the patient create something. So that, and this, of course, I'm mentioning this here in terms of recognition processes. That is, each therapist and patient, each physician and patient create their own system. And it's quite important to understand that what we're involved with, and this is, it's been a very interesting thing to teach a seminar here about this, that in addition to offering whatever particular knowledge or interventions we're offering, that we're also constantly building a relationship. And that the psychotherapy process, and indeed every intervention process, involves the development of a relationship. And so we come to the 4th point. I see that my PowerPoint is not exactly the same as my list of points in my notes, but what I call the intersubjective perspective, that's not my term, is that in general, relationships, the intersubjective interaction, the intersubjective between subjects, between persons, the relationships are the basis of development and personality organization. And that so we know that the most important variables in predicting developmental outcome in general are relational variables. That's particularly true in the mental health area. That this is not to overlook the importance of genetics, but in most cases and with most presentations, and in general with regard to personality organization, relationships are crucial. And this, of course, this should not be taken as an overgeneralization. Developmentalists and developmental psychologists have always been concerned to see what predictions can be made from early childhood to the future. It's very difficult work to do because there are so many intervening variables, and you have to keep subjects for a very long time. And this work, what you also need, I'll give you a little hook to the research. What you also need to do that is are variables which you can measure, which persist over the life cycle. That is, what can you say about a baby, which you can also say about a 25-year-old? And the best work in that area in the mental health personality organization has been done by the, I'll get back to this, but by the attachment researchers following the work of John Bowlby, the original. I'll assume there's some familiarity with attachment research, which describes the nature of the tie between the infant and the parent, roughly at 12 months of the infant's life. What our colleagues at the UC Berkeley Psychology Department, led by our late colleague Mary Main, Nancy Kaplan, Carol George, Judith Solomon, developed was an instrument that interviewed adults and found correlates of attachment in adulthood. And the usual correlates, by the way, are the narrative coherence and the interest in communication are the greatest, are the measurements of individual and attachment security in adulthood. Now that's another thing to learn more about. It helps you listen to patients. The attachment researchers have found remarkable correlations between security of attachment or insecurity of attachment at age 12 months and in adulthood, with approximately 0.7 correlation. That is, 70% of the time, if you know the attachment classification: secure, insecure, ambivalent, insecure, anxious, disorganized. If you know the attachment classification at age 12 months, you'll predict the attachment classification at age 25. That's a remarkable correlation in general, and it's a remarkable correlation in developmental studies. Here's an even more remarkable correlation. The correlation between the attachment classification of, that is, are you secure, make a long story short, are you secure with others? Do you have a sense that there's somewhere will have somewhere in the world that you can come back to when in distress, or someone who will, from whom you can move, whom you can use as a secure base, which leads to a sense of being understandable, which leads to a sense of having a secure self. The correlation between the attachment classification of a parent and that parent's child at 12 months is similarly strong. That means that we have intergenerational correlation between attachment classification, the security or style of finding security at 12 months, to that baby's child at 12 months. This is a remarkable correlation in developmental science. This is one of the ways that I can show you that relationships are important. And if I leave you with one takeaway in regard to adult psychotherapy, it is that don't forget the relationship in a moment-to-moment way and in the long-term way. And I must say that that's something that no one would disagree with, but many overlook in practice. What I want to do now is go a little further into the research on infant-parent interaction, and give you a little sense of how these ideas were developed. Through the late 20th century, I'll say, and into the early 21st century, the general feeling about infants in all of the health fields was that infants were essentially incompetent. Freud, a generally smart, brilliant, for one of the great psychologists, psychiatrists of our culture, at least of the culture of the Western white men, Freud considered infants the closest correlates of what he called primary process, of disorganized, timeless, instinct-driven experience. William James, the founder of American psychology, called the mind of the infant a blooming, buzzing mass of confusion. Through the mid-20th century, I'm going back away, but through the mid-20th century, physicians were taught that, and other health professionals, that infants were born blind at birth. I couldn't believe this, when I first came into the field. This was not the conviction when I came into the field in the 1980s or so. I couldn't believe it. So I asked some of my older colleagues, and they said, yeah, that's what we were taught. Infants are indeed not blind. They're not best understood as being confused. They're highly dependent, of course, but babies are, when alert, babies from the beginning of life are able and interested in other people and are among the most evocative humans of all. The sense of babies being dependent is countered by the extent to which babies are influential in regard to their families. There are few events in the life cycle as transformative as becoming a parent. I say that not only to make a generalization, but also to orient you to the extent to which infants are influential. And a correlate of that for my discussion of psychotherapy is to remind you that you are continuously influenced by your patients, your state of mind, your physical state, your emotional state. Indeed, if we had an ongoing discussion and we'd look at some videos of infants, and you do, I know, people in training do, watch your videos and watch how your body changes moment to moment. Your posture changes in relation to what happens with patients. And that's not just true in the quiet of the psychotherapy office, but even more true in the hustle and bustle of hospital work, consultation work, and the like. Recently, some of my colleagues who are working in inpatient unions say, this situation, this bureaucratic situation with this patient makes me feel and act like a monster. This is certainly an example of system influence and mutual influence. Think of the tension that you feel. One of the things that I want to say then is that if you think in terms of mutual influence systems, you begin to think of your experience as a psychotherapist, and I'm perhaps telling you all things that you already know, as a source of information, not something to be dismissed and not something to be ashamed about, but something to be understood. And this is something which I think we still remain ambivalent about. I'll get to mutual influence a little more in a minute, but let me describe one or two of the early and still relevant experiments which showed the early interest in the social world of infants. I could, I'm not sure where the camera is, but I'll use a couple of, if I have them, and I should have them, I'll describe it to you. Picture a device called an infant theater. Imagine those of you in the audience or at home, in your office, are the infant. And you're looking at a screen, and the screen at first presents you two images. One is a circle, and the other with the same, let's say the same perimeter, is a square. All we're going to do in our experiment, if you will, is to watch where your eyes land and go. Infants at 24 hours prefer overwhelmingly the circular image. Infants are endowed, human infants, primates in general, but particularly hominids, are endowed to prefer rounded shapes. Now, this is one of those things that you act out implicitly, or many of us act out implicitly, when you bring a thing that you put in the crib of a little baby. No one ever buys a teddy bear with a square head. You don't give kids robots until they're older, not even soft robots. I have a daughter. When my daughter was born, someone brought her something to put in the crib. One side was a mirror. A mirror made no sense to her until late in the first year. They don't. The other side was one of these black and white things which had oceany waves, ocean waves and rounded clouds and all. And infants from the beginning follow the outlines of these things and follow and look. I say prefer, you watch the eyes, that's where I'm going to look. I'm going to look at the circle. Now let's take another setup. Now we know circles are preferred, and we're going to we're going to put up 2 circles, and we're going to take 4 little shapes inside the circles, smaller shapes. If any of you are old enough, I think you can still get these things in a museum. Color forms, they're sort of sticky, they're sticky shapes that you can stick on shapes. In any case, I would draw it, but the tech didn't all work despite all the help. 2 little circles and a kind of roundy oval, long-shaped oval, you know, long, extended, elongated oval, and a rounded shaped triangle. And I'll array one set of those. I'll array the circle here. Can you see what I'm doing? The circle is here. This is the big circle, little circle, roundy triangle over here, and elongated oval here. No particular way. The others I'm going to align in a human face. 2 little circles, roundy triangle, elongated flat oval. I'm going to ask you, the baby, by just watching you, and the human face is preferred. The human face is preferred at 24 hours. I can go on in this. This shows us something, again, that every mother knows, that human faces are preferred to other stimuli from the beginning of life. Infants prefer high-pitched voices. This is another one of those everybody knows. If you're, go to the supermarket and you're kibitzing with some mom with a little baby and you want to get a little attention with the baby, you won't talk in a low voice. You'll talk in a high voice because that's what babies prefer to hear. Hi, Molly, hi. Maybe not so shrieky, but that's the way that it goes. Infants are generally familiar with intrauterine life is influential. As you know, we know that intrauterine life is influential. Intrauterine life is influential with regard to chemical exposure and the like, but we also know that infants will respond to environmental conditions, not only the mother's psychophysiological state, but also environmental stimuli like music. If you play a fast rock sound in the room, baby's heart rate will speed up. If you play some soothing ballad or some tuneful classical piece or something or other, the baby's heart rate will slow down. Things are happening from the beginning, and this is not a pro-life argument that I'm making. Things are happening in the late stages of pregnancy that are already making a difference. Infants are thought to be more familiar and with the voices of other people who have been around them. That is to say that the conversation between the baby and the environment is proceeding in the last months of pregnancy and continuous. Infants then are in continuous conversation with their environment. And what I want to say about psychotherapy is, and I'll say a little more in the time that we have, is that infants are patients, and you are involved in a dialogue with continuing mutual influence. Now, I'm going to see if I can pull up a video that I want to show you.
Ja, nogen kan rigtig godt lide dig, ikke også? Ja, hun kan sig. Så det er så hyggeligt, når du snakker. Så det er så hyggeligt. Du snakker så til mor. Ja, ja, hvad er du fortæller? Hvad har du savnet din mor? Har du savnet din mor? Hvad? Ja, det tror jeg, det du har. Jeg har også savnet dig. Ja, jeg har også savnet dig.
I hope that gave you a sense of some of the infant and the parent, very little baby, where the mom is going, and the baby is responding and watching, and so on. And, oh, great, thank you. And we'll just go with this. And so what I'll say, and I'm, of course, being extremely schematic here, is that, let's see if we can get this big. No. Okay, anyway, is that the patient and the therapist in psychotherapy are engaged in continual processes of self and mutual regulation, and that this is going on at a nonverbal level. And so if you're talking psychoanalytic ease, we come to the contemporary paradigm psychoanalysis, which is transference and countertransference is a mutual influence process. That is to say that, probably I can best illustrate with an example. What I want to do is to, and this may be something you're very familiar with, but I want to encourage you to think of your interaction with patients as a mutual influence process. Just for example, I don't know which case to say. This is the first meeting of my week. Otherwise, I'd have something right off the top of my head. But you know, I'm about to go to my private practice office, and one of the patients I'll see today speaks very rapidly with a slightly irritated tone. My responses to that patient tend to be clipped, a bit more clipped. I'm a little riled up. And with the next patient, that other patient thinks I'm quite grand. The second patient thinks I'm quite grand and says, oh, I'm so happy to see you. And I will react in such a way as to go, okay, this is okay. And then I have to tell myself, no, it's not okay. Something is going on. He missed me over the weekend, something like that. And rather than be tempted in this case to say, oh yeah, I must be a good guy. That's one example. In an inpatient case that was recently presented to me, it's not the monster case, but one of my colleagues, one of the people that was involved in our seminar, was presenting a situation in which the patient, simple example, the patient wouldn't stop looming verbally over her. Here again, we have the importance of the nonverbal. And the patient was looming over her. This is not so surprising. And it was upon reflection, she understood that the patient was very frightened. But of course, instead, she understood herself as being frightened. She was frightened. She became more militant in responding to the patient, and eventually the patient was put in restraints. We discussed the case, and subsequently, I'm over dramatizing, but you see, this would be a mutual influence process. Subsequently, when she was more able to reflect on her fear as a response to the patient's fear, all of this nonverbal, subliminal, she was able to treat the patient as someone who was frightened. And the patient, while of course not calming down, this is no panacea, but she was able to become less frightened, and the situation was stabilized without restraints. When she first called for restraints on the patient, she also felt terrible about herself. And the treatment alliance diminished. And in the second example, the treatment alliance at least remained alive. This increased the likelihood that the patient would comply with other aspects of the treatment program, including being willing to make appropriate discharge plans. I don't mean to be utopian about this. I don't mean to say that this is going to work in every example. There is all kinds of pathology, including very serious pathology, but this is a rather simple and if glib example of something that really happened. And in this case then, to make my further points, it was essential that the therapist, the attending, the resident, understand herself as being influenced non-verbally, and being influenced in the channel of affect, not words. This was a situation in which the technical intervention, not necessarily a wrong technical intervention, but the technical intervention was driven by non-verbal influence process, which led to a mutual influence process. I'm being scared. Imagine if that mom had scared the baby. You're scaring me, mommy. Mommy gets more scared. Affect is contagious. Emotion is contagious. Facial displays of affect are registered at speeds faster than 1/10 of a second. Faster than 1/10 of a second. Mommy, you're frightening me. I become frightened, more frightened, and since I'm the one holding the keys, I'm going to frighten her back. This is the kind of process that I want to draw more attention to, and in both in psychotherapy, other mental health intervention, and also when we're consulting and supervising, and so on. I think I should stop here and take questions. Perhaps gratuitously, I'll just add one last thing and then give you a quick recap of what I said. Here are some of the future pathways for infant development research. There are quite a few. Attachment theory and research, continuities between infant and later development. I've touched on those. We've touched on direct interventions with infants and their families, autism and other divergences, cognitive and affective neuroscience, trauma research, cultural, racial, economic, immigration, and all their effects on infancy. We know from prominently the adverse childhood experience studies that all stresses in all these areas, including family, have long-term effects on health, mental health, and employment status. And I've mentioned a great deal already about policy and policy implications. I've tried to show that infants are social from the beginning, that caregiving is essential. I've said something, more could be said. I've said something about the critical importance of infancy for subsequent development. I mentioned attachment research, just mentioned the ACE study. I've discussed the importance of early care, the nonverbal creation of meaning, and the implication of attention to the nonverbal and mutual influence processes in interventions of all sorts. I've mentioned at the end, and again, it's a long story, but what we know and are knowing more and more about the fundamental importance of affect, of emotion in directing attention and in organizing intrapersonal and interpersonal processes. And I've tried to take note of ways that could, all of those things, especially the last, affect, nonverbal, mutual influence, thinking relationally, can be imported, depending on your perspective, to mental health practice, including and especially psychotherapy. So thank you. I'll be glad to take your questions.
Dr. Seligman, if there are questions in the audience, you can choose.
Oh, I don't see any, but I'm glad for them.
Okay, well, thank you so much. I do not see questions in the chat either, but I guess I will ask you a question.
Okay, thank you.
So as you can see, we are currently in a situation where talking about relationships and connection, we're still post-pandemic or through pandemic, and we've acquired a number of new habits, such as joining conferences by Zoom because of the potential convenience, certainly.
Yes.
And so I was wondering if you could comment about that, because I think that part of the relational and connections and contagion effects, in a sense, that we are seeing may also be intercollegial. And just your thoughts about that, and what if you've had any
Sure.
initiatives or any thoughts about that.
It's not my field. But I think that one of the things about this area that I'm presenting is it's a sensibility about a sense of integration and personal presence and so on. So excuse me. I'm in my own practice. It's taken me a while to get back to working in person with most of the people I see. I mostly have a psychotherapy practice and consult to community mental health and other workers and therapists in private and university and so on. I think it's nice to see other people, and the sense of community is very important. One of the things that I miss a lot when people are not meeting up in person and coming to events like this in person is just the creative possibilities of unexpected and random interchange. I think that is, the talk is the talk. It's probably more lively if you're here, but it's a lot of trouble to come over here in the morning and go back where you are. Traffic is getting worse. We have to work harder. Might be better to see an extra patient than can come over here. But what one misses is the creativity and personal support that comes from being in a situation like this. And I think that's invaluable, and it's invaluable in my career, is invaluable to my personal development. And I think it's absolutely invaluable to the development of our fields. So I'm a big fan of getting together.
And it's also, I don't know if others have comments, but there are questions in the chat. Okay, let me look at them. Actually, if you could pull them up. Okay, so here is a question from Mary Burke, who says that you're a major influence on her career, and is asking for your comments on the impact on parents and caregivers of preoccupation with a cell phone. Like, how do you see this as potential?
Right. That's a great question, Molly. Thank you. Good to hear from you. It's a fine child psychiatrist, adult psychiatrist, Dr. Mary Burke. I don't like it. I'm distressed. I think everything that I've said goes to the extent to which I'll put it this way: both infants and young children, everybody does better, and we know this as a matter of health outcome, does better when they're in interaction with other people. And if you believe, as I do and my colleagues do, that interaction in which you can affect someone else to make a response which is coherent with your initiative is pro-development, pro-health, pro-mental health, then having a kid be on the cell phone or on the screen too much, or a parent being on the screen and essentially leading parallel lives, is going to be a life of many missed opportunities. Now, I get it that parenting is hard, and parents can't be attentive to their kids all the time. But I think that what we know from the data is that, and what we know clinically, is that mutual influence and mutual recognition creates a sense of vigor and vitality. That if someone looks at you when you look up, it matters. If someone looks at you when you make a sound, if your friend responds to your enthusiasm about a show you just saw with a weak, it doesn't feel good. So I'm concerned about that, you know, and of course the data is concerning about overuse of screens. I think we have time for one more. Yeah, but no?
I think we don't technically, but one of the things that I will say is that it's very important that you're reminding us of these principles. And one thing maybe that we should all think about is also the position of the speaker who comes in, because I remember these big debates in medical school when already medical students 20 years ago didn't want to come for a lecture, wanted just the notes, and how we were debating what the disadvantages of allowing them to do that would be. And I think at the end of the day, it was also for the speaker, because it's true that the talk is a talk, but at the same time, you're taking your time to come here and talk to us. And this response that we give you in person is also important.
Well, that's kind of you. I mean, I think you're right. It's not as much of a pleasure to talk on the screen, even if you see the people on the screen, you know, but I'm grateful to all of you who've come. And, you know, it's one of those cost benefit things, but of course, one wishes there were more of us talking around. And I'll hang out for a few minutes. And I'll hang out on the screen also in case anyone wants to check in for any particular reason. And you can write me, of course, Stephen Seligman, .Seligman at UCSF.
Thank you so much.
Thank you all very much. Thank you.